Welcome to Health Focus, where we focus on your health. I'm your host, Dr. Scott Anderson, and May is Melanoma and Skin Cancer Awareness Month. And it's a good time of year to ask ourselves, are we doing everything we can to safeguard and protect our health? And not just our overall health, but actually the health of our skin, which is such an important part of our body and so critical to our longevity, our appearance, and the way we feel about ourselves. We're very fortunate to have with us an expert in this field, Dr. Geisse, who is a local physician, who is not only a dermatologist, but also a dermatopathologist who's an expert at looking at microscopic tissue from the skin. He's actually the founder and medical director of Solano Dermatology Associates. He's a graduate of Indiana University School of Medicine. He's a longtime faculty member at the University of California at San Francisco, who has taught doctors in training in recent years and for many years in the recent past. And so I think I couldn't have a better guest to have on the show to talk about this topic. Thank you so much for being with us, Dr. Geisse.
It's a pleasure.
So skin cancer, it's getting more attention than it used to, but I get the feeling just in seeing patients and talking to friends that the awareness still could be improved. What's your experience from your perspective as an expert?
I think it's getting better, but we have a long ways to go. We're on the upslope of a bell curve that's alarming with increasing skin cancer incidence worldwide.
Okay. And of course, you treat some of the most advanced cancers with your expertise in, for example, this procedure that's called the Mohs procedure. But I guess from my perspective, as critical as that is, if we could educate people to prevent skin cancer, that would be even better.
Of course, skin cancer in particular is preventable in many ways, and certainly death from skin cancer is usually preventable from early detection and early intervention. So awareness and screening is critical to that.
So if I were to ask you, what causes skin cancer in general, before we talk about specific types? What is the cause?
The main cause is sun exposure combined with genetics, combined with age. So the more sun you get, the longer you live. And if you have a genetic background that predisposes you to skin cancer, it's almost uniform in those patients. But everybody can get skin cancer no matter what their background is. It's just rare in some groups compared to the typical blue-eyed, red-haired person.
I'm glad you brought that up because I think that we often tend to think of skin cancer as being something that people are prone to when they have a very fair complexion, when their genetics is perhaps of Northern European extraction, Irish, Scottish, Scandinavian. And we know that individuals who, like my wife, are from the Philippines, may have somewhat more darker skin, have more of the protective melanin in their skin. And obviously in Vallejo, we have a very diverse community with all ethnicities. It's where you practice, and I know you do a lot of work among underserved populations. I do think it's important to point out that we all need to be aware of skin cancer. Is that a fair statement?
Absolutely. The skin cancer in general is seen mostly in fair-skinned people who burn easily. But anyone who's had intense sun exposure as a child and sunburns, and everyone can get sunburned, is at risk for skin cancer. And we see in Vallejo quite a bit of skin cancer from patients who grew up in Southeast Asia and Central and Southern America, intense sun exposure, even with darker skin.
What is the latency period? In other words, if I'm exposed to sun cancer and I'm a teenager who's out swimming or doing sports, how much time goes by before the cancer appears typically, realizing there are different types of cancer?
Decades. So even one bad sunburn, a blistering sunburn in particular, increases your risk of melanoma and other skin cancers over your lifetime substantially.
And sunlight has different kinds of what we call ultraviolet light. There's ultraviolet A or UVA and UVB. Which one is the biggest culprit? Are they both a problem?
They're both a problem. Turns out A is more of a problem than B, which is a flip to what we believed 20 years ago. So the old adage, be careful between the hours of 10 and 2, that's when ultraviolet B is at its most intense, the burning ray, ultraviolet B. But A, which is dawn to dusk, penetrates through glass. It penetrates more deeply in the skin. So things that you see that people call aging, yellow, sallow, wrinkled skin, brown spots, that's really sun damage. And that's mostly ultraviolet A. And A, unlike we thought just recently in the past few decades, is probably the major culprit, but they work together to cause skin cancer by damaging your DNA.
I know that you and I both were children, perhaps in the 1960s and going into the early 70s, being baby boomers, both of us. And I wonder if you agree with me that when we were kids, the approach to what it meant to be tanned was different in many individuals. There was this perception, perhaps fueled by Hollywood and images of, good-looking movie stars with nice tans, that a tan was a sign of being kind of healthy and fashionable and sort of hip and cool and having the time to go out and lie in the sun. And yet, really, it's good to reconsider that sort of approach and think about it in light of the information we have now. Would you not agree?
Of course. Tan is your body's attempt to protect itself. So the reason skin cancer is more common in people with fair skin is they have less inherent or natural protection because the pigment in the skin helps block those harmful rays. It's a natural sunscreen. So tanning is really sun damage. And it's a myth that people think it's healthy. It certainly does help you generate vitamin D sun exposure. And so our patients who get a lot of skin cancer who do not get any sun exposure, nursing home patients, et cetera, they need to supplement their vitamin D, no question.
Right.
But like tanning booths, I equate those as a dermatologist to smoking cigarettes. It's a known cancer-causing agent. And around the country, we have sororities in the Midwest who have tanning booths in their sorority homes. It's like crazy. Right. And we've had kids tanning with tanning booths thinking it's safe because it's mostly ultraviolet A. It's completely incorrect. Plus, it increases the appearance of aging. And so with young people, we do a better job of saying, you need to not get sunburned, stay out of the sun, wear hats, wear sunglasses, wear sunscreen because you're going to look old and wrinkled.
Right.
Skin cancer is too far off, and it's not something that they immediately worry about. But that's something that strikes home to everybody. It's like, oh yeah, and no matter what pigment you have in your skin, sun damage ages your skin.
Gotcha. Well, now that we've talked a little bit about skin cancer in general, let's talk about some of the specific types of cancer. So we'll use a little bit of medical terminology here. First of all, with the cancers that are really potentially more readily curable, I'll let you comment on that. Let's talk about, for example, squamous cell carcinoma. Is that the most common cancer you see in your practice? I understand it's increasing in frequency from discussing this with you.
In my lifetime of dermatology, 30 years, that's a long time in my career, basal cell cancers outnumbered squamous cells 3-1. Now, squamous cells are probably outnumbering basal cell cancers. And it's pretty alarming. And those are more dangerous than basal cell cancers. So people don't really die from skin cancer very often. Melanomas, squamous cell carcinomas, other more rare cancers do kill people. Basal cell cancers, which are very common, aren't very dangerous usually, but they can be disfiguring.
So the squamous cell, although we think of it as being often localized, like all cancers, it can metastasize. And I think particularly in the head and neck, I'm aware of a few cases where this has metastasized locally and gotten into some deep tissue in a way that's potentially even life-threatening.
Absolutely. I have patients dying every year with skin cancer, squamous cell carcinoma. So other squamous cells, which are also caused by carcinogens. Smoking causes tongue, the larynx, the throat, lung cancer, known carcinogen. Those are mostly squamous cell cancers. The human papillomavirus, which is what's called an oncogenic, a cancer-causing virus, that causes squamous cell carcinoma of the cervix in women and genital squamous cell carcinoma in men and women. Now with the HPV or human papillomaviral vaccine, that should be a thing of the past, hopefully, because those are viral-induced squamous cell cancers.
In fact, we've done a few shows on immunizations and vaccinations, and we've had in some experts from the county, and I'm a strong advocate for vaccinations for any kind of disease that could be prevented in a safe manner. And I think the reason why the vaccination for human papillomavirus is so important in what they call tweens or preteens is because you want people vaccinated before they're exposed to these viruses, and they are typically sexually transmitted. So,
of course,
vaccinating someone who's 12 years old does not mean that we want to see that person be sexually active. We want that person to be protected.
To be safe for a lifetime.
Yes.
It's something that we felt very strongly about. So strongly, I left UCSF academics full-time, in part coming to Vallejo because we had a large research unit, clinical research unit. And we opened a whole office in Davis to attract, at that time they only studied women with the original vaccine, young women who were documented to be not infected genetically with the human papillomavirus. And our Vallejo-based practice was the largest enroller in the country of that original study that led to the approval of the vaccine. Now there's better vaccines, but it's so important. It's the only vaccine we have that is an anti-cancer vaccine. There'll be more soon, particularly with the new mRNA vaccines. Hopefully, the vaccines that we're now seeing for COVID, those can be used almost certainly, maybe even in my lifetime, for squamous cell cancer, melanoma, and basal cell cancer, the three biggest killers.
Okay, so we covered squamous cell, Dr. Geisse, and you did mention a little about basal cell. Would you like to tell us just a little more about basal cell, what it looks like when you see it, and how you identify it?
They can look like scaly rashes. They can be big open sores that don't heal when they're very advanced. An old name for them was rodent ulcer, like a little hole in the skin. Those are very bad basal cell cancers that can damage nerves and even get into the bone. They can go into the brain if they're neglected. They are, I call them the Rodney Dangerfield of cancer because they're low grade, they don't kill many people, but they cost society a fortune because there's so many of them and they're so common, and we have to manage them at this point in time, mostly surgically.
Rodney Dangerfield, who famously said, "I don't get no respect."
Right.
So this deserves more respect. Well, let's move on to malignant melanoma. Now, obviously, this is a cancer that really strikes fear into the hearts of many people because it can metastasize widely and cause death. If I'm not mistaken, we've seen kind of an epidemic of melanoma as the baby boomers, the post-World War II generation, has gotten older and had more sun exposure. That's my impression, but could you educate us on that?
That's correct. Fortunately, while the incidence of melanoma, just like squamous cell, keeps rising, the mortality or death rate is actually lower, except for men over 65, so we're out of luck. But, and that's probably because those patients don't seek out care promptly, because if you catch melanomas early, it's curable, eminently curable. So most of the melanomas I treat, which are now, I don't know, 6, 10 melanomas a week. Just 20 years ago, that I would have been flabbergasted to see more than 3 or 4 in a month for my procedure, which is called micrographic surgery.
Okay.
So something is very wrong, and it's probably not all sun. Air pollution, ambient radiation levels from any source of radiation, other carcinogens in our environment must be playing a role here. It's mostly sun because we can measure that in these cancers.
On the subject of melanoma, let's talk a little bit more about populations in whom we may miss melanoma. I'm thinking of Bob Marley, the famous reggae singer. I think he succumbed to melanoma, right?
Yes.
And the presentation or the way he came to the attention of the doctors was a little bit unusual. Can you tell us a little bit about that?
Yes, it was what's called a subungual melanoma beneath the nail on his his big toe. And those are deadly because they're often misdiagnosed and not recognized until, as what happened to him, unfortunately, late in the stage. And so he did show it to a doctor. If you watch his biography, that was a wonderful film. Mm-hmm. And they kind of didn't diagnose it and missed it, and then he lived with it, and he suffered with it. It was hurting them, and by the time they caught it, it was too late. And so, in fact, darker skinned patients get melanomas in funny places, underneath the nail, in the mouth, on the bottom of the foot. Places you don't think of getting a skin cancer because it's not sun-related, it's a genetic issue. Not all skin cancers are necessarily from the sun. Some are induced partly by viruses. We talked about Merkel cell carcinoma. Some of that's from a virus and the sun combined. So melanomas underneath the nail, usually it's the thumb and the big toe, on the bottom of the foot, inside the mouth in darker skin patients are quite dangerous because doctors and patients don't think cancer.
And I guess in melanoma, we would be remiss if we didn't mention the eye as well.
The eye you can get melanoma in the eye, not related to sun as well, a genetic defect, and those are also deadly because they're missed.
So let's say somebody has seen the show and is following our sort of advice, your advice, minimizing sun exposure, applying sunscreen, and so forth, avoiding tanning booths, but still has concern about this. Is it a good practice for people to examine their own skin? Should people routinely have their primary care doctor examine their skin? I say this in part because, particularly as we get older, it's hard to even see our own skin.
Of course.
So what's a good screening procedure just for otherwise healthy people who are now concerned about this? What's the approach?
Well, people who are at risk, so again, a person who's fair, blue-eyed, has had sunburns, it would be reasonable for them to be screened by either their general doctor or a dermatologist. Somebody who's not necessarily at higher risk can screen their own skin using 2 mirrors, have a partner look at the places they can't see. And cancers in general are not static, right? They're changing. So if you've got a skin lesion, no matter what it looks like, because these skin lesions can look like melanomas can be pink, they don't have to be black.
Really?
Basal cell cancers can be black, they don't have to be pink. And they're difficult for non-dermatologists to identify frequently. But if you have something that's changing, that's new or growing, well, that's a big red flag. So if you have a mole or nevus that's changing, that has a 500 times risk of becoming or being a melanoma. So when we follow patients who are at risk, we do take digital photographs now, made it much easier. We put it into digital records and we can follow a skin lesion over time, and if it's changing, it comes off.
So you mentioned nevi, or what are commonly called moles. I recall at one point learning, perhaps you can tell me if this is right, that among healthy people, particularly of Northern European extraction, a normal person may have 200 moles and be totally normal, as many as, they can be widespread. So obviously at some point, most of us are going to have moles where if we look at them, we may wonder if they're suspicious. There are other lesions, long names, which you know better than I do, histiocytomas and normal lesions that may be on the skin and appear to be deforming somewhat but are normal. So I would think almost everyone at some point would have a suspicious lesion.
That's partly true, and there are not enough dermatologists to provide that service. So our general practitioners, our family medical doctors, our internal medicine doctors, even other people in related healthcare industries, if the awareness is out there, I've had many cases sent to me by hairdressers, massage therapists, of cancers. They're like, I don't like the looks of that. And it doesn't necessarily have to be an obvious cancer that's bleeding. If you have a cancer that's bleeding, that's a bad sign. We need to catch them sooner than that.
Right.
So, but when you mention 200 moles, that patient with 200 moles, they're at risk for melanoma, substantially higher risk statistically.
So that's a high number.
Yeah.
What
And
is
if
the
they
normal
have
number?
more moles on the arms and legs, little ones, they're also at higher risk.
Okay. Now, If you see someone and you see a mole, obviously you have 30 years of clinical expertise and experience as a dermatopathologist. Do you ever use serial photography? I remember that used to be a thing.
Yes, we do that all the time. And we also use a handheld magnifying lens called a dermatoscope. That's not a microscope, but with skill and training, you can look at benign lesions and get a good idea of what's benign or not cancer versus what might be cancer, decreasing the number of biopsies that are done unnecessarily. And then their device is coming out. I'm on the board of a scientific advisory board of a company that uses something called elastic tissue spectroscopy to scan skin lesions for GPs to give you an indicator of whether it's bad or needs a referral to an expert. So we're getting better at these things.
When people come in to see you with suspicious lesions, about how often do you do a biopsy? As opposed to just a
Well,
clinical
my
assessment?
practice is skewed because I only see skin cancer and only referral patients. But for the average dermatologist, an older person with blue eyes, fair skin, the odds are very high that they might need a biopsy if they get a full body skin check.
Okay. So some people may be a little bit afraid of the process. So let's just walk them through. They come in, even if they have one suspicious lesion, I believe most dermatologists make it a practice to do a complete skin evaluation. Is that correct?
Yes, if they're thorough, that's correct.
Okay.
That's a good provider.
How do you biopsy a lesion? I mean, how's it done?
Well, if you have a suspicious bump, like let's say for basal cell cancer, you would clean the skin, use a local anesthetic. We use a 30 gauge needle. We go down the hair follicles. We take the pain out of the anesthetic by using something called sodium bicarbonate to buffer it. And so it really doesn't hurt very much. And then you take a knife and lay it on its side so you're not cutting into the skin and you shave the bump off. It's a pretty trivial procedure. People have hurt themselves more, in their daily lives than that little biopsy does. And there are other biopsies that, if it's suspicious, where we might go deeper and put stitches in. Or if somebody has a funny rash, we use a little cookie cutter knife called a punch biopsy. Mm-hmm. But the anesthesia is what people, and the needles are what people are afraid of. But we can make the procedure pretty painless.
Of course, you're locally extremely well known, I would say perhaps internationally, for your work with the Mohs procedure. Can you tell us what that is and when you use it and what it accomplishes?
Yes, well, first of all, it's a tough name. Frederick Mohs, M-O-H-S, was a German-trained surgeon at the University of Wisconsin, a general surgeon. The real name is micrographic surgery because we use microscopes, we make maps to map out cancers, usually of the face or eyelids or fingers or genitals or toes, places where you don't want to cut out skin unnecessarily. That's normal. So we track out the cancer under the microscope while the patient's there looking at specialized frozen sections. So frozen sections that are done by regular surgeons, if you think about a pie, a pathologist gets a piece of the pie, a slice, and looks at it on end, crust, filling crust, with a little window of it that's only 5 microns thick. So if I cut something out and send it to a regular lab that's cut into 2 or 3 pieces, the sampling is less than 1%, with less than 0.1%. With this Mohs procedure, we section it on the bottom. So we would take that pie and flatten it out and cut across the bottom so you see the whole crust and underneath. So
And
it's
these are-
very different. So we get 99% cure rates.
99, excuse me for interrupting you. These are pamphlets from the American Academy of Dermatology.
Yes.
And you have these available in your office, I
Yes,
take it.
for patients, correct.
And
You can order them from the American. This one's from the Skin Cancer Foundation. But it's similar.
Wonderful. So 99% cure rate. Do you do a frozen section in the office where you actually look at the pathology in real time and then go back and keep digging? That was what I thought it was.
Yes, so Mohs surgery or micrographic surgery, the surgeon and the pathologist are the same person. We remove the tissue, we make a map, it's made into slides immediately, and then we go back to the patient if there's more cancer left in a precise way, relatively precise to regular surgery.
So how long does the whole procedure take?
Well, that depends on the cancer. I've had one from, I shouldn't say names, but it was a neglected cancer from a large institution that took me 3 days and 188 frozen sections to clear. And we can get little basal cell cancers on the nose that we can do one section, clear it in 20 minutes, and they go home without a reconstruction. So it varies.
Do you feel optimistic, Dr. Geisse, about the future of our efforts to prevent and treat skin cancer? I'm thinking, for example, about cases I've seen where people have been treated with immunotherapy for melanoma that would have been fatal previously. I feel that we're making progress. What do you think?
Remarkable progress in melanoma, not so much in some of the other skin cancers. Recently, the most fatal skin cancer is called Merkel cell carcinoma, much worse than melanoma. So recently, there's things called PD-1 inhibitors that are helping those patients who die half the time. And there's also new treatments for squamous cell carcinoma. We're getting into the end of the treatment. Again, it's better to prevent these and then catch them early, and we don't need those advanced treatments. So hats, clothing, sun avoidance, sunscreen, vitamin D supplementation, that is working, because if you look at recent data in this country, younger patients have a slightly decreased incidence of skin cancer than they did 10 years ago. In Australia, where kids, you never see kids outside in Australia without a hat, and the hats have the cowls. All the playgrounds are covered in Australia. They have socialized medicine, so they spend money on patient education nationwide to put hats and sunscreens, and the beaches clear out in Australia except for the tourists.
Right.
Midday.
I should mention too that we are kind of oversimplifying. You mentioned, is it Merkel's syndrome?
Merkel cell, it's rare,
Merkel
but it's
cell.
also increasing like other skin cancers.
Right. And even as a non-dermatologist who sees internal medicine cases, I'm aware too that there are skin lesions that may come about due to internal issues. For example, breast cancer can erode through the skin. You can have cutaneous T-cell lymphoma from a blood problem. So it just points to the complexity of dermatology.
Dermatology is a wonderful field.
Yes. And I believe that the skin is it the second largest organ in the body?
The first largest.
First largest, and it should be considered an organ.
Absolutely, and it's a complex organ. It does all kinds of things.
Right, absolutely.
Yeah.
If anyone is interested in getting in touch with you or your practice, what's the best way to do that if they feel that they would like to be evaluated? Should they go through primary care and be referred? I guess it depends on their insurance and so forth.
Depends on their insurance. So if you can't go to a specialist directly, you'd have to go to a primary care doctor to be referred. We have 5 offices: St. Helena, Napa, Vacaville, Fairfield, Vallejo. And we have providers, both physician assistants who are experienced and trained, and dermatologists. There's 3 Mohs surgeons in our group. So somebody like me, I don't see patients except referred patients for surgery, and they come from all over the place. And we do, sadly, too many cases because patients are still unaware of what a problem this is. So.
Well, Dr. John Geisse, I want to thank you for joining us here on Health Focus as we focused on melanoma and skin cancer awareness. And I want to thank you for all of your efforts in the community to serve the entire population. And I hope that we can continue this conversation.
It's a pleasure.
Remember, here at Health Focus, we focus on your health. Today, we've been focusing on melanoma and Skin Cancer Prevention Month, which is May. And I hope that all of us in that month will make every effort to really enjoy our beautiful Northern California weather while at the same time being safe and taking care of our health. So wishing you the best of health. We look forward to seeing you next time.